Go figure, you get diagnosed with PAD, you are in shock, you're sitting in the consult room, and you can't think of one question. So you go home and what do? You go to padsupportgroup.org and you send them to us with the Global PAD Association. And we have Dr. LaMar Mack from, what would I say? It's Central California is where you are located. What, about an hour south of Fresno?
Correct. That's right.
And how do I pronounce it? It's Kaweah?
Kaweah.
Kaweah Hospital.
Mhm.
And he is a vascular surgeon and he's volunteering his time. So excited to add him to our network. We were introduced to him by Reflow Medical. A couple folks there said, he's the man. So, of course, I have to talk to the man. And I'm excited because we have a lot of patients that are excited. And our friend Marie went scouring through the group looking for all of the questions for you, doctor. And we have quite a few. We even invited a couple folks in here into our live studio audience to ask you some questions live because they're a little bit more in depth. And sometimes it's more fun to have a full case study so you can show us how you interrogate a patient.
Absolutely. My pleasure.
So can we start with just where in the world did you get this foot fetish? Don't you like the way I phrased that
I
question?
love it. It's phenomenal. Honestly, this was something that came to me. It wasn't my, most kids who go to be doctors want to go to med school. It wasn't one of the things that first came to me. But interestingly enough, throughout the course of my training, I had some really good mentors who were able to show me the aspects of vascular surgery and things that we were able to do. And so, you take that, you take those skills, and then you apply them sort of personally. And obviously, you live in communities where you see a high diabetes rate, you see a high amputation rate. You have, as a matter of fact, only probably 2 or 3 years ago, a very close family friend of mine had both of her legs amputated. So it's one of those things where my grandmother had her legs amputated too, actually while I was in training, interestingly. So that made for a very interesting family discussion from my side of it.
Like, why didn't you call me? Help?
Well, she had already had a bypass, and they're like, well, she did this. I said, well, that seems reasonable enough. And again, this was 20 years ago. I said,
Oh. Well, technology was so different 20 years ago. I mean, isn't it incredible that you probably think back going, if only I had this tool? They weren't doing the below the knee work that they're able to do today. I mean, even today, there's still a revolving door, for so many patients, but they just didn't do it for the most part. They couldn't. They didn't have the small tools and the finesse.
No, not at all. And so, yeah, it really just developed into this thing where you really want to continue to give back to the community. And you see it, as a clinician, you see the despair sometimes, or the
Yeah.
disheartening when that news of the surgery happens. And you really want to be able to, not let that happen. And so I think as time's gone by and I've grown, both as a clinician and as a community member, you really just want to change that. You want to change all those dynamics, and figure out ways to, do your best to try and help these people, save their limbs and not have to get amputation, not have to undergo such a traumatic, both physically and emotionally, type of ordeal. And so I think for me, that's where I really want to sort of, be able to help move these needles for patients.
I mean, you know what it's like to have a family member and a friend that had been amputated. You don't want to amputate. Describe, because one of the doctors says it's a really bad day for me when I have to amputate.
Yeah, it does. It becomes a rough day. I think for me, the day of isn't as bad as the day you got to tell. To me, that's always the hardest, when you've kind of, when you've pushed through everything and you've done it all and you've hoped for it. You really, I've just seen people just completely break down in front of my face. They were doing fine, and then the word comes out and the entire room shifts. Then you do the surgery, and you do your best to get them through. But yeah, those first days leading up to it are really, really tough. And you see the word on their face when you're getting them ready for surgery. So those are some hard times. Absolutely.
Have you ever had a situation where the patient had to console you? for having to your sadness for having to, um, do the amputation. I imagine because there are some of those people that are like, "Doctor, I'm gonna be
They,
okay."
they do. I had one. I did have one. It was way after. It was a young lady who I treated. She wanted with bilateral amputations, unfortunately. But I was really encouraged because again, we're a relatively small community. I think our town is about 140,000 strong, but you see people almost on a regular basis. And I think I was out to eat and I actually saw her walking down the street with her prosthetics. And so she was, you get to see the smile on her face, her husband's face, of how far she had come with that. And so, I think that was one of those cases where I was like, okay, she said she felt better. She said she was doing better. She looked like she was doing a lot better. And so I was encouraged, like, okay, while none of us wanted this to happen, you know, you being strong and supportive and happy that you feel better, you're like, okay, well, at least, unfortunately we had to do it, but I'm glad you look and feel better.
Describe a case that is one you still think about today that you learned the most from, that you think others could even learn from. It could have
Oh.
been a success, it could have been a failure.
I think, well, for me nowadays, I think, as you pointed out earlier, we've got so much more technology than we did even 5 years ago. And so the ones I see now are, there was a gentleman I had who actually is a dialysis patient. And this to me speaks to listening to the patients and allowing them their self, for lack of a better word, resolvability. I don't know what the sort of adjective word of their own resolve is, but this is a guy, I actually had to put his dialysis graft on his leg because he had run out of other accesses. And he started to get some black toes. They were a little crusty, as most dialysis patients can transition to. And we worked on it. We did a couple of angiograms. We were able to fix them. And I think we got to a point, he had maybe one vessel run off and the toes were all black. And he said, "Doc, absolutely not. They are not like, you're not cutting off my leg. I don't care what happens otherwise." And he just had toe amputations. To this day, I still see him to follow his access, and he kept his leg.
Good for
So
him.
he was like, "No, absolutely not." He's like, "I got too many things to do. I got my family I got to take care of, and these things, like, you can't do that to me." And so we didn't. I said, "Okay, we won't." Um, but I think that one to me is like the one guy who's like really, he was really steely in his resolve. So you appreciate that and you respect that.
I love it. Have you ever had a case where we love cases where you talk about a patient that kicked butt with walking as medicine and just blew your mind what they were able to do?
Oh yeah, I have plenty of those. So I use those patients in my practice all the time. Um, because we see sort of all spectrums of arterial disease, whether it be treatable or not. I have probably in my cadre at least 10 or 15 patients who to today still have completely occlusive disease. But because they continue to walk, because they continue to exercise, because they continue to go, I see them probably once a year, once every 6 months, and they're doing great. I mean, they're like, my leg doesn't hurt. They don't have any wounds. They don't have anything like that. No gangrene, no sort of leg changes, and they are doing fantastic. So I say, you know what, buddy? Keep up the good work. Keep on going and do what you're doing because it's work. It does it at the end of the day, it does work. Not everybody falls into that grand success, but yes, absolutely. They keep getting up and they tell me, "Hey, I'm trying to walk 2-3 miles a day," and they're doing it. They're absolutely doing it, and they have continued to maintain their legs. Absolutely.
The ones that I see where it just doesn't work and until they can really get the blood clots mitigated are people who tend to clot, whether it's if they have AFib or valvular issues or aortic aneurysm. I've even seen people throw clots with cancer or they have factor five or any of those. And it's sometimes, if you end up unstable at any point, there they go right down the legs. But And I'm sure you see a lot of those. I see a lot of those down the aorta and into the iliacs.
Yeah, so AFib, we don't see it as, I don't think we see it as much anymore because we have like the Eliquis's and
Mhm.
the Xareltos and things of that nature. But that used to be a very typical sort of, it was always the middle of the night case. That's the one it always was. We would get called in the middle of the night, a patient had a cold leg, and you'd go in, you'd treat them, and you'd look on the monitor, and sure enough, they were in AFib. Did you miss your medications today? And they say yes. And you look at especially when we were doing a lot of Coumadin, their INR was low. And so he's like, well, okay, that's what we do. You get the scan, they're occluded. And then you could go in and you could certainly, remove the clots.
Yeah.
Fortunately, relatively quickly in those situations. But yeah, I know we still see it periodically, but I haven't seen a lot of those recently as much as I used to. Probably the early half of my practice, maybe once or twice a month easily. Now maybe 2 to 3 times a year. But again, I think that's a consequence of, as you point, some of the medical advances with the Pradaxas, the Xareltos, the Eliquis, and things of that nature that are much easier for people to stay regimented on.
As long as they get diagnosed in time, as long as they go to the
Absolutely.
doctor.
Absolutely. Yeah, that can't be
Get
the first time
diagnosed
you
in
find
time.
out you got AFib for sure. Yeah,
But
you don't want that.
how do you normally, with those, and I know it's different, but we've had way too many cases where as frontline treatment, they want to do an axillary bifemoral bypass without even going in and at least trying a TPA, trying something to just melt the clot, going in endovascular, getting a better look.
Yeah, no, for me, I always like to get some type of angiography, whether it be a CT scan or diagnostic angio. I do think, the surgeries, we like to jump to surgery a lot. I've got quite a few colleagues, and I'm working on certainly ways to do some of these endovascular revascularizations to the aortoiliac segment. I'm an old school trained doc, and so I am trying to untrain some of that of myself. But I will, back then, yeah, we would just do an open elegant surgery because it looked, at least clinically, a lot better than the endo treatments. But I agree. These days we have such new tools. We have, newer stents, we have newer balloons, newer ways to cross and access lesions. I certainly believe that any patient, you sit down and you talk and you give the options, and you should have the ability and the access to try something. At least give it a try. If it doesn't work, okay. And that's what surgery's for. Sort of these days become a good fallback, but certainly give, any and everyone a shot at, a more minimally invasive and, not as aggressive type procedure for sure.
Yeah, I mean, our philosophy and, with our medical board of directors, which you are going to soon be a part of, huh? Right? Um, the philosophy and how they have us guide people is it's not frontline treatment unless it's emergency, aortic infection, that it's even considered in the NHS as more palliative care, but there are serious situations where it is the only option. And we have one of those that's here, and we're trying to help her understand what to expect and that life is not over. And she's young. I think she's in her 50s still. She looks like she's about in her 30s. And she had an infection in a graft that was placed in the iliac, and it literally corroded. It corroded. And the surgeon called me, he's like, Kym, this is like the artery's gone. Everything's gone there. And so just curious, your thoughts now. He said he went in, he at least got down to the SFA, cleared a little bit of a landing zone. So in a couple weeks, he can go back in if she's okay with it to do an axillary bifemoral bypass, might be able to do submuscular. Would you mind just talking her through that and helping her with the right questions to ask the doctor and what the recovery process and any tips you can give her?
Right. So the first thing I think, you sort of want to know the process. Okay, where are they going to go? Which vessels are they going to use? And what type of material are they going to use? The reason I say is because with the previous infection, That's always a concern. Do you want more prosthetic in there that can get infected? So are there things that they're going to do, or how are they going to mitigate a recurrent infection? Because right, that's a big deal. And then the second part is you do want to know sort of people ask me about recovery, and I always have to pause and I ask them, what does recovery look like? Because everybody's definition tends to be different. Some people just want to know how long they're going to be in the hospital, how long, are they going to be back until they're normal, all those kind of questions. So, if you can, sort of separate, what the hospital stay look like? Will you be going home? Will you be going to rehab? Where are the incisions going to be? Are they going to be in places that are important? Which one is one going to be worse than the other? You're going to experience more pain. Obviously, with extensive surgery that you've already had, repeat surgery is going to be a little bit more challenging. And so how are they going to navigate the repeat portion of it? Where are they going to go? Will there be additional surgeries? What's the monitoring going to be? All those kind of things, I think, put into it. And then what are their expectations based on your anatomy? Like, do they expect you to feel 100% better? I personally think a lot of patients tend to appreciate, even if you did an okay job, not a great job, an okay job, if the surgeon sets the expectations from the beginning, saying, I expect you to be, walking with no problem in, 8 to 10 weeks. Or, yeah, we're going to get you mobile. It's going to be tough, and you're probably still going to have a little bit of pain based on what I see with the anatomy and how the blood's going to flow and change and things of that nature. So I think, those are all appropriate, and it's easy to wrap your mind around it once that happens.
Fantastic. I hope Marie, if you have any questions, you can stick them in chat if that hopefully is helpful. I want to follow up with that. Do you have any patients that, have continued to do well with that as long as they've mitigated their risk factors and they're walking?
100%. I used to be, and I'll be 100% honest, I love doing the big aortic surgery. I'm a vascular surgeon. I love doing it. And traditionally it had been what you do. If someone's under, 65, chronic, aortic disease has been going on for years, not sort of the acute stuff, but the long-term, you just do an aortic biofilm and they would crank along. I've got some I probably did back in the late teens that are still walking around. I actually have a lady, she's in her 60s. She actually quit smoking because we did the surgery. So sometimes it can be a good deterrent. But I did her bypass, and we still monitor to this day. I've had to intervene on it twice. And that's just balloons. Like, we went down one leg and just ballooned it 2 times, right where we sewed into the groin. And I saw her 2 weeks ago. And from a bypass and blood vessel standpoint, she's doing great. Unfortunately, she's got some arthritic problems that are still causing her pain and problems. But from a leg claudication type standpoint, she's still doing phenomenal. This is probably 7 or 8 years out.
Now with the arthritis, you can do a little genicular arterial embolization. It's just some of those, little abnormal vessels.
Yeah, hers is spinal arthritis.
Oh, they do have that too for that. There's some doctors here in Marin. I didn't know that it was possible, but over here in Marin County, they just talked about some orthopedic surgeons that are working with IR on that.
Oh my goodness, that's
I know, right?
Send that on down. Send that info on down. We got a lot of people, a lot of.
I love your energy. We also have a patient we have Adrene. And since you were talking about the love for doing those big surgeries, what I tell people, if you do have someone and it's time for you to do it and they love doing it and they're good at it, that's the surgeon you kind of do want to go to. So maybe Adrene, we have to ship you out here, but Adrene, do you want to give Dr. Mack a quick hello and give him the Cliff Notes version of your case and where you are? Where did she go? I want to call her Adrian, but it's Adrene. But oh no, I think she might have just fallen off. She was here just.
No, I was muted. I'm sorry. I was
That's
muted.
okay. Oh, well, hello, Adrene. Um,
Hi.
I'll let you
I-
have the floor.
I'll just give you a really brief history. 2024, I had my first two stents, kissing stents, placed. And then in September 25, I went back in and had to have the right stent restented. They
Okay.
put a stent inside the stent because it was blocked. And now I went back this morning and my ABIs are pretty bad. And they are now talking, I cannot pronounce the word for it, the A for something bypass.
A
Y'all can say that word.
aorto, it's the aorto bifemoral bypass.
Yes. So Kim and I were talking, and help me phrase it, Kim, was it the size of the stents that might have started all of this that were placed
Yeah,
to
we've
begin
had a
with?
quite a yeah, we've had quite a reign of undersized stents of
Yeah.
late to our Lifesaver hotline, including there was an SMART Cordis stent that was placed. And I was like, I don't see anything in the mod database on the FDA's website. I'm wondering if it's operator error. It ended up, slipping. It migrated. I'm like, I have a feeling they just put in too small of a stent. They didn't use intravascular ultrasound for sizing and placement.
Yeah, no, I mean, so right. So for me, and that's totally possible. So I've heard of this before, and yes, the answer is probably they are too small. Some of the guys do it sort of blindly. And you look at the artery, you say, well, maybe it is. Now, I was just at a conference this weekend, and a lot of us were talking about that and doing IVUS to size arteries because they're right. You just, especially the plaque is eccentric, meaning that it's only on one side of the artery, not concentric all the way around. You just don't really know how big the artery is because you're looking at a 2D image. So if you change it the wrong way, you may be looking at something that looks 6 millimeters, but it's really 7 or 8 because the plaque is behind it, and you're just seeing this flat sort of plane there. And so we talked about using IVUS. I am a converted sometimes IVUS user to a most of the time IVUS user. But when it comes to iliac disease, I usually have a CAT scan on the front end, and I try to measure the stents based on the aorta. And so if you've got the aortic diameter, then I just half that for each of the iliacs, as long as it's not super big, right? So if you've got, for example, a 16 millimeter aorta, I may use 2/8 as long as the iliacs aren't, 5 or 4, or they aren't 10 or 11, then you have to go bigger. So you have to sort of, I try to gauge it that way as long as it makes sense in that nature. But to your point, yeah, it's probably the stents were too small. And I've seen that once or twice. But
So,
Yeah, it's crazy. We see it. It's great. We see it all the time. I see it a lot. Actually, over in the NHS, they don't use IVUS at all. And then we just had one. Thank goodness her sensors are clear, but she knows, the next step. But you can, right? Go ahead and get them cleaned out. If she has a lot going on, right, Adrene, in your life right now, you don't have time for recovery. If you could get another year out of these stents before going for a big bypass, is that the type of discussion that you do have with patients, Dr. Mack? And is that okay, or should she be afraid?
no, I don't think you should be afraid at all. I do think if it's worth it from your lifestyle and ambulatory, certainly look at a second opinion. I'm always a fan of second opinions. I got patients who look at me as like, is that, and we go down the same pathways and like, is that it? I'm like, well, listen, I got a buddy down at UCLA, or I got buddies here. Like, absolutely give them a call and see what they think. Because I hopefully am self-aware enough that I don't know it all. I try to be very good, but I hopefully, know that there are things that I'm missing. And so I do want patients to have that access. And because neurobiofilm is a big deal. I tell people it's probably one of the biggest deals vascular surgeons do. Usually anywhere from a 4 to 7 day hospital recovery, just depend upon, how things go and, how you decide to sort of ride out in the ICU. You do have a big abdominal incision that you got to get over, and then it's sort of the recovery from all of that. And so if that's not what you're up and ready for, then yeah, absolutely, try and see if there are other ways to sort of open the stents up, at least temporarily. There's some newer scoring type balloons and things that might be beneficial, atherectomy devices, crossing devices that all may be helpful to, like you say, get a little bit more time out before you're ready. The other option that I've also had people do is, they just keep trying to do their walking programs and keep up with it. And they kind of, for lack of a better word, deal with it as long as it's not too crippling until they can get to surgery. Again, because it does tend to be a big deal. So you certainly have multiple avenues, and I would certainly try to see if someone's willing to, again, try one of these crossing techniques and, hope for the best with that. Absolutely.
Yeah.
Thank you.
Is that helpful, Adrene?
Yes, it is. Thank you.
You're welcome.
Okay, good. We have a great surgeon over there in the Myrtle Beach. I think, is it also Charleston, South Carolina, Adrene?
Yes, he's in Hochberg's in Charleston.
Yeah, he's Christian Hochberg. I don't know if you've heard of him, but
USC?
um he might have been, but he's now in
He's
Charleston.
private. Yeah, he's in Charleston. Definitely. Yeah.
Oh, but he's not an MUSC doc. I know some of the MUSC guys. I don't know anybody individually, but
I think he might have been there for a little bit, but I'm not sure if he's still there. But yeah, he's a good surgeon. He can do it all. He's been around the block for a while. But I love, and I think it's so good for you to say, and so good for people to hear that, you know what, a good surgeon is going to say, you know what, I don't know everything sometimes. Why don't you go see one of my buddies? And my buddy's going to tell me honestly, slap me around a little bit. Why didn't you think of this?
yeah.
I was just in with Marie's doctor, and Marie's doctor at first told her, well, at first I thought the axillary wasn't going to be possible because she didn't have a landing zone. And, when they were talking about clearing out the infection first, I said, well, doc, what about if you're in there, why not take a wire down and see if you could figure out something, in the SFA? And he said, actually, that's a really good idea. I was so worried about the infection, just seeing occluded, that it just did not cross my mind, and he was able to do it. So they are open. A really good surgeon is open to different ideas. So that's really good for people to hear. And we have a question on here from Gary the Holiest. Is there an optimal distance to walk to really get those vessels going?
So
Don't you love those questions?
I love that question because the answer
he's willing to walk.
He is. The answer honestly is no, distance wise. So if you're saying, well, should I walk a mile, 2 miles, 3 miles? The answer is no. What I tell people, so there are two sides to this, there are two answers to this question. And I'll tell you, I had a fight, I shouldn't say a fight, but I had a rather spirited disagreement with some colleagues of mine at one of the conferences last year because they look at claudication and say, well, if you can walk a mile, you're good. To which my response was, well, I live in an area, Central Valley, California, a lot of farming, a lot of fruit trees. A mile ain't going to do it for some of these guys that walk. Their day is 10, 12, 15 miles because they're walking up and down. They're going up and down ladders, going down groves of trees and all that. They got to be able to do more than a mile. However, if a mile is within your daily sort of whatever activity, then a mile is good. And that's what I tell patients. If you're doing a mile and a mile makes you happy and a mile as good as you can get and mile as far as you want to get, that is totally fine. If the answer is 10 or 15, then a mile isn't. What we typically prescribe, so that was part A. Part B, what we typically prescribe for patients, especially moderate to severe claudicants, is at least 30 minutes of walking a day. Okay, 30 minutes of total walking time, meaning if you walk, say for example, you can only walk for 10 minutes at a time. If you walk for 10, try and go for an extra minute or two, but the minute you cannot walk a single step more, the clock stops. Take your break, take your rest, start to feel better, and do it again. And continue to do that until you build up to 30 minutes. So that's typically the pros around being able to walk and schedule and structure and schedule walking programs. But again, if you can do more, I tell people as many as possible. It's interesting. I read some articles periodically, and they were talking about the whole 10,000 steps thing. And I
That
think
was
it's
our
great.
next question.
Yep. Yep. I think it's great, but it's not 10,000 ain't necessarily the goal for everybody. So it's more of the consistency, I think, and the regularity. So again, if for you 8,000 is sort of the push, I think if you can do 8,000 steps 3 to 4 times a week, then you have it. And you will build up, right? Because for me, I'm a runner. I do all kinds of stuff. 10,000 on a normal day for me is a breeze. So I wouldn't shoot for 10. I am going to shoot for 12. So I think it all just depends on, at least in my mind, when I talk to patients, it kind of just depends on where you are in life. You know, we get some poor, you know, we get some patients that are 89 years old and they're not going to walk 10,000 steps. They might get 6,000 around their house or their garden, or 8,000. And so I'm happy with that. But if you, for me, it's the consistency. You know, 3-4 times a week at the space that you're at. I think that, and the studies are showing that it's more about the consistency than the actual distance.
You're a lot kinder than I am. So in our
15.
structured
I want 15
program,
now.
we tell them your steps don't matter because we have 20 to people that are saying, I do 20 to 30,000 steps per day and my claudication is bad, but I'm like, are you walking through the pain? Well, no. Okay,
Right.
well then here we go. This is
Yeah.
what we're doing. You know, don't care if you're just,
that's
you
the
gotta
key.
push through, right? You gotta push through the pain.
Yes. That
And I
is
love
the
that you
absolute
said,
key.
yep. And you said, hey, when the pain gets so bad, then you stop. But we also, we start people off with, we tell them, because I know that Vanderbilt's walking program on their website, their structured walking program, that it gives you a rundown on how to, you know, do it is, okay, you need to walk 30 minutes. But the problem is that a lot of people, it takes them 90 minutes or more to get those 30 minutes in, and people work and they have other responsibilities. And so where we start people is we tell them the clock's going to keep going. So you have 30 minutes, set 30 minutes aside, and that's going to be day one. And you're going to walk as far as you can, pushing through that pain. I want you at a level 7 or 8. I want you really up there, not grinding your teeth. We had someone crack a tooth, not on our watch, but he did. He was like, I was pushing it. Now I'm at the dentist. And so, you know, you don't want to, that's my example now. You don't want to do that, but you want to get to the point where you're cursing my name and you're getting to a level 7 or 8 pain, because that's when you're really telling your body, we need a new route for blood to flow. Your muscles need oxygen. So come on, get on the stick. It's just like when you go to the gym and you're doing that bicep curl and you're doing 3 sets of 15 and you get to number 12 on the final set and you're like, I feel like my arm is literally going to break off. You know this. Like you feel like you just can't. It's going to fall off. It burns. It hurts. Your blood vessels that are popping out of your forehead. And it's just that, give me one more rep. We say in that moment, give it one more step. Just feel, if you remember what it's like to work out and do those leg presses or do those arm curls, and you're giving it that just that one more, that's what you got to do with your legs. And we're so used to just walking, right, as normal, that, you know, you don't think of working out and pushing it, but you can, and you can really, really push it just to a 7 or 8. And over time, what we notice over 2 or 3 weeks, they're actually getting up to that 30 minutes of walking. And then we're going to start to increase the pace. And so it's just gradual, but it was too hard. We found that everyone was dropping out of the program when I initially said it and said, nope, 30 minutes, you have to do 30 minutes. How many people? We had a 13% retention rate. Now we have an 85%.
Yeah. Yeah.
So
No, I'm with you 100% with everything. I will co-sign all of that you just said. Absolutely. Co-sign. Good.
I'm going to have your signature with your picture in the corner of the app. Okay, we have quite a few other questions, you know, coming in here. I think you answered the one, if we walk 10,000 steps every day, is there a significant possibility that our toes and feet could regain their balance and mobility as they were before? Has anyone experienced this?
Yeah, no, not the balance part. That's something different. That's something, honestly, I would refer to a physical therapist, because there's more going on there than just the blood flow. So there's a little bit of neuromuscular relearning that'll have to happen. And so a podiatrist or a physical therapist will help with, as you regain blood flow, then you have to retrain the nerves and the muscles about balance. So yeah, 10,000 steps won't help balance, but it will help blood flow, and then the ability to retrain. So the tolerance will be there to retrain for that part.
And I know there's another one. It's probably you're going to just repeat a little bit. I want to open it up. If you are on YouTube, youtube.com/the the way to my heart, make sure you subscribe to our channel, but also put in some questions. We have our amazing producer, Josh, that's gathering questions. Also, I know we have more and more here in our live studio audience. If you do have questions, go ahead and raise your hand or put it in into chat. We are live, but you don't have to show your picture if you don't want to. You can just stay off camera, but we can get your questions in for Dr. Mack as well, who's generously donating so much time. So thank you. Here's the other one. Okay, I can walk extremely slow for 20 minutes, sometimes more until I can't anymore, or I can walk at a normal pace for up to 10 minutes before I have to stop. Is it best to do one or the other, or does it not really matter?
Better do the normal pace.
Yeah.
It's just, just back to Kym's analogy of working out. When you're doing the workouts, you're really exerting yourself. So you're at maximum effort or max effort. And so walking it's the exact same analogy. You want to be as high in effort as you're doing these walking programs as possible. Obviously not running, but yes, I would say normal pace over slow pace.
Yep, totally agree. Got to push it. And Wanda is joining us here. She has an occluded CFA. We want to do a bypass on her, but she wants to see if she could build collaterals around there. She wants to walk through. Is it possible to build collateral vessels there?
Around I'm assuming you're seeing the common femoral artery.
Common femoral artery.
The answer is 100%. That actually is where you have a lot of large built-in collaterals already. So interestingly enough, the arteries from the iliac, so in the pelvis, and the profunda, which is the second branch in the thigh, they already connect, surprisingly enough. So we see a lot of patients with common femoral disease that you would think should have gangrene. Like their disease should be much worse. But because of those already built-in collaterals, they are just claudicant. So they do just have some walking pain. So the answer is absolutely you can before surgery by walking. Those collaterals will beef up. Those arteries will get very, very large. The profunda especially gets huge. I've seen very big profundas on some patients. Again, who've had this chronic disease and we've done nothing for, and they just keep on going. So yes.
That's really encouraging. I hadn't heard that yet. So that's awesome. Okay, was just recently diagnosed with PAD in her feet, been wearing compression socks, but everything she's read on the internet says that is a no-no. Is that true? She feels like her legs feel so much better though with compression socks on.
Yes.
And I think that there's just a little bit of a misnomer, right? So it just explain where the differentiation between the two, where you can and you can't with PV.
Yeah, so remember your I have to tell people, go back, remember your circulation is really just a big circle. So heart's at the center, blood goes down through the arteries and comes back up through the veins. And so PAD, P-A-D, is peripheral arterial disease when you get to the nitty gritty. So that involves the blood vessels going down to the foot. And so what you're reading is that, yes, when you have peripheral arterial disease, you don't want to put the compression stockings on because the pressure head from the arteries getting the blood to the feet are already compromised. And when you put on the compression stockings, it further compromises them, and that's what can cause ischemia. I actually have a clinical story where I saw that happen in real time, but we can do that later.
Oh, would love that.
Yeah, the other side is the venous side. So that's bringing blood back up to the heart. So the bottom of the circle is your capillaries, toes, and all that kind of stuff. So the veins come back up to the heart. And they are under much lower pressure. And so for that, the issue is you want to get the blood from the distal portion back to the core so it can pump up to the heart. And that's where those valves in the veins that people talk about don't work very well. And so in that situation, you have venous disease or venous insufficiency. That's when you wear the compression socks. And that's probably why you're feeling, because in fact, what you have is venous insufficiency, not necessarily peripheral arterial disease. hope that helps.
Yeah. And they can, and if they have both, we do have some that have both, and they just have a mild PAD, and with the mild PAD, they still, to get the swelling down, they'll do a very light compression.
Absolutely.
And
So
your
you want I can
story.
tell you the story? Yeah. So there was a patient I got called on here who had foot wounds. So it's sort of global. Now, mind you, we have a pretty big homeless population too. So people come with all kinds of stuff, delayed presentations. And he had pretty bad toe wounds. They were purple. They were bluish purple. So bad, but not awful. He also had a lot of swelling. Well, the team at the time, which wasn't my team, so I had no knowledge of this, but they had started to do Una boots on his legs for the swelling. And so they were like, well, his toes are blue. So we went back and I looked, and on his skin, he had serious PAD, like almost like occlusive disease. Well, by the time I got involved and they had done the Una boots for 3 or 4 days, his toes had turned black and they had switched to gangrene. And so I tell people all the time, that can happen. And you've got to be really careful. So anyone with venous disease, I tend to try to test for arterial disease too, and tell them, listen, I can turn blue toes black if you let me, but I don't want to do that. I want to make sure that we've got enough inflow that can overcome the compression before we do that. But yes, it'll happen.
Have you had any really sad cases on ECMO where they weren't even a vascular patient and they ended up coming in with an infection and they've ended up with amputations? We lost in the past year, we lost 4 sets of 4.
Yeah, I do see the ECMO patients. It wasn't even because they had infection or anything. We just saw our heart program. If you get someone in really bad failure, you have to put them on ECMO. And I think because their filling support is so dire because of their heart, once they get on ECMO, that flow just sort of stops.
Yeah.
And they sort of thrombose. So we've had quite a few. I've seen quite a few of those one that did lose their limb. One I think we were able to recanalize. We actually do this trick where you can recanalize the artery distally to the ECMO, and then have the blood pump down.
Ooh, you need to teach that one.
Yeah, so it's sort of one of those last ditch efforts. But yeah, you can ultrasound the artery distal, put like a angio catheter or some kind of catheter, hook it up to the ECMO, and then the ECMO allow the blood to flow through the leg. So I've done that a couple of times.
Oh.
We've had people on heart support for bypass. So what are those things called? Impellas. And they cause artery problems. So we had to go back and try to endarterectomize or do some sort of salvage maneuver. Still lost their leg, unfortunately, because everything just thrombosed, and it was, unfortunately, it got too far down the road to salvage. The other one, we don't see it so much now, obviously, because things have changed, but I will say during the pandemic, we saw a lot of that, just because what we found out was, and we tried, I mean, we were doing all kinds of stuff to people for the first few months, but the infection would just take over. So it wasn't the surgery that did anything. They would just die. They would go from a mild to moderate case to a really severe case. And so we did stop a lot of operating, revascularizing operations from clots from COVID, because that was a really tough time. That was a really sad and tough time during that. I did have one guy though who I thought died, but actually survived after all of that. So yeah, we worked on. He was same sort of story. Had sort of a moderate case of COVID, limb thrombose. I mean, it was truly non-salvageable. We did his amputation. He still had it. He was still positive, and got sicker. And so we were following. I think we changed shifts or something, and one of our partners on call. And we kind of lost track of him. I was like, man, I thought he died. So he comes into my clinic probably 8 months later, like, no, I'm still here.
That's great.
So you get some, I mean, there are some, really good success stories. Some you don't like, but we've seen quite a bit here. And hopefully,
But I like your ingenuity. I like that you're willing to learn, you're willing to try, you're willing to get on a phone with someone else to say, hey,
Absolutely.
Does anyone have an answer? Because I want to do some, I really want to do something. And I think that I think patients really do appreciate that. And even when you have a doctor like that, there was a conference I went to, patients are going to love this. I went to a conference, it was a ophthalmology conference, and they had an actual room where they were teaching the doctors how to encourage patients to go get a second opinion. And they were showing the stats that more than 75% of every patient that is encouraged to go get a second opinion actually come back, whether or not they got a better option, because the trust in you as the doctor that's saying, hey, I'm open to it, whatever you want to do, let's go. They're just like, you know what, I'm going to stick with you. I think you have my best interest at heart. So
We try. We try for sure.
So Sharon has a question. She's in our live in studio audience. I assume she wants me to ask the question for her. Is it normal to get pain in one hip and glute more than calves when walking to create collaterals? It looks like she had femoral endarterectomy in both legs, which I still think the CFA and DART, right, is still gold standard.
Yes. Yeah. For the femoral, yes. You can't really stent that because of the flexion in the hip. My suspicion is that there's blockage higher up. So you probably have some sort of aortoiliac disease. That would be my initial question. Obviously we, do ABI or ultrasound workup and see, but if you're having hip and buttock pain when you're walking, that's typical of iliac artery disease. And so it certainly can be unilateral on one more so than the other.
I always ask because I've had quite a few patients that have had bypasses, fempop bypasses that have gone down, and no one ever bothered to check the inflow. I'm not kidding.
I'm sorry.
No, but and we just had, where was Wanda? Wanda had that same situation, that they never checked her inflow until just recently, which is how they just discovered.
There are three tenets. I tell patients all the time, especially when they have a bad bypass or something like that. I say there are three things you need when you're considering, especially a bypass. There's inflow, there's outflow, and then there's the conduit. So what you're actually using. Those are the three things that make or break a successful bypass. Inflow is by far, I think, the most important. You got to get blood going into the thing. I can tell you how many times I've had claudicating patients, and all we did was iliacs, and they felt better. That was it. We just did their iliacs, fixed their iliac disease, and they felt better. And I would say, hey, we can eventually go and fix your SFA or this, that, or the third. And they're like, they come back and they say, dude, I can get around now. And so I'm like, okay, we'll hold off until we need to do something else. But if you're doing good, then we're going to leave it be. So.
Can you quickly go through the difference between inflow, outflow, the conduit, so that people understand, and what questions they should feel comfortable asking their doctor before the bypass?
Absolutely. So inflow is the blood above the blockage. So the blood flow above the blockage. Remember, everything comes from the heart. So anything above or heartward of the blockage, if you talk about the arms, that's a different story. But from the legs is anything above the blockage going down. Outflow is what's after the blockage. So what arteries are you going to that are still open? And then conduit is just what the thing is made of. So that comes from the old, when we just used to use vein for doing these bypasses. And so you needed a good, not only size vein, but a good sort of strength of a vein. So the vein couldn't be really warped or flexible or sort of diseased in order to use it. So you really wanted a good conduit. So the vein had to be really good in order to make the bypass successful. And so those are things. So is there enough blood coming in, the inflow? Is there enough blood to be able to get out? So it has to go somewhere. So if you bypass to a closed artery, it's not going to work. And then what are you using to bypass with?
And I think Wanda, the questions, yes.
Yeah. So, I think with any surgery, the bypass questions, we talked about earlier, still all the same. What does hospital recovery look like? How are you going to keep monitoring this? How are you going to follow it? and sort of what to expect. The higher level stuff is, so what's my outflow look like? Because I think that's always important, because that will dictate the expectation. You know, 1 vessel versus 2 vessel versus 3 vessel outflow. What are those things like? Would it be possible to go and re-intervene at some other point in time? Will you have to do that? How often would you have to go back and re-intervene if it's necessary? And then what are the changes I have to make sure this thing stays open? What are we going to do medically, diet-wise, exercise-wise, all those kind of things.
Yeah. And what about, I think one of the things that she was sharing with me was a fem-fem, and I hardly ever see them anymore. Everyone that I've seen, I send them to a different doctor, and somehow the patient never needs it.
Mm-hmm.
What are the actual Hail Mary indications for it, and why are more and more surgeons saying, I would rather not do it if I don't have to?
I think the problem with the fem-fem is
You're
one,
robbing Peter to pay Paul.
yeah, but we've also come so far in fixing it, because it typically was a surgery for isolated iliac occlusive disease. So if you had just like one iliac that was occluded, but you didn't want to go through an aorta biofem and AXFem, that's really, the AXFem is really the last ditch effort. But that was the sort of things like, oh, they've got just the one iliac. The other's fine, but they're claudicating, so you want to kind of get around that. I think our techniques of iliac repair are getting better. And so now we can isolate, you can iliac stent or iliac reconstruct isolated without having to do a fem-fem. And it just doesn't last. It's in a really dicey area. I think they probably get infected more than most of the other bypass grafts, because it's groin to groin. Groins are bad themselves. And then it sort of comes across the pelvis, which is a really wonky area. And you're just sort of digging through the skin under there, sort of right on top of the muscle, and it's got a bend, and it goes over the ligaments and things of that nature. It's a really wonky type of bypass. If I could avoid doing those, I certainly would. But I think I do use that as it's not my last, that's the AXFem, but it's my next to last ditch.
Yeah.
For that kind of stuff.
Yeah, we had one of our board members, and I know that if she has to do one, I will never question whether or not she's going to do one, because I know for her, like, she's going to try every other method, but she's going to make it work, right? You're going to try and make it work when you do. I know we're on top of the hour already, and I know you have to get back to clinic. Can I ask you a few more questions that we had come in here?
Sure, absolutely.
So we had Yvette, another walking question, it looks like. ABI 0.68 stenosis or occlusion identified in her 10th week of walking with pain every day with zero improvement. Would an angioplasty be good at some point?
I would 100% do an angiogram on you. An ABI 0.6 suggests moderate. I say moderate. I'm a hyphenated person. Moderate to severe disease. Severe is technically like 0.5 or less, but 0.68 is really darn close in the grand scheme of things. And the fact that you're continuing to have discomfort even with the walking program. So what they probably saw on, did you get an ultrasound or ABI? Remind me real quick.
She got an ABI.
Okay. So I would probably just go ahead and do the angio, or you could get an ultrasound, because what they'll probably show is either one of two things. You've got iliac disease, and so you actually see normal ABIs with iliac disease. It's a really weird phenomenon. But in the absence of anything else down the leg, that's probably the reason the ABI is so low, because again, that sort of big flow coming in is compromised. The other thing is you may have just sort of disease all the way down. And so even though they say there's no stenosis, you may just have sort of really long segment stenosis that nobody's identifying, or occlusions. So I would absolutely, for me, if you were my patient, I would absolutely get an angiogram at this point to identify, at least get an angiogram to identify what we're looking at, whether it be a CT angiogram or direct angiogram, just to say, what are we working with here? Like, what sort of issues are you having? And why do you keep having pain in spite of there being quote unquote no stenosis?
Okay, and we have another question coming in online here. What if any pain medications help to control the pain of CLI and neuropathy? Something to take, at home, not while in the hospital on an IV. Because what I've heard is gabapentin and Lyrica and Oxy, like they don't even cut ischemia pain.
Nope, they won't. And that's what I have to remind patients. One, the federal government has made it really hard for us in narcotics. But at the same time, right, it's not going to work because of the mechanism. The mechanism is the lack of oxygen. And so for me, the answer is let's solve the lack of oxygen problem first. And then we'll see, then we can sort of mitigate the nerve pain, stuff like that. But yeah, absolutely. Until the actual occlusive problem or the stenosis or the blockage is fixed, those medications aren't going to touch it. Not maybe I tell people, yeah, it take the edge off for 30, 45 minutes. It's going to come right back. And that is absolutely what they tell me.
Okay, Betty wants to know, she says she walks every day for her PAD, but what's the best avenue for CVI? She walks, she takes statins. She has a history of small intestine AVMs. So her cardiologist said no blood thinners. Since folks take blood thinners after surgery, it seems surgery is out for both conditions. Maybe. What do you think? Any thoughts on my case?
So CVI, you mean venous insufficiency or for CLI?
That's a good question. I mean, CVI, she said she has both. So I'm assuming that it's chronic venous insufficiency.
I would certainly continue walking. It sounds like medically you're doing all the things you can. At 81 milligrams of aspirin, honestly, people they've done the studies. The bleeding rates are exceptionally low. I mean, everybody worries about the ulcers, gastric ulcers, but it's shown that it does not worsen gastric ulcer bleeding. AVMs, I think there's still data to be obtained, but I would assume the same is probably true. The bleeding risks are equal to normal population at the 81 dose. I would not add things like Brilinta, Plavix, or Xarelto, Prodax. I wouldn't add those things, but certainly at 81 milligrams would be fine. For the arterial side, for the venous side, if venous is what you've got, chronic venous insufficiency, then compression socks, perfectly fine as something to start with.
Okay, we have quite the conversation going, starting with Bob on here asking about walking. Why can you walk easily one day and then the next day the pain comes a lot quicker? They have people replying, good question. It's so frustrating. Push to the graveyard. Also, he says, I walk a lot more if drinking alcohol. Is it because it thins the blood and better flow to the legs and calves?
I hear you. Wouldn't recommend.
Aren't you glad you came?
Aren't
you glad you came?
I love it. Listen, this is a day in clinic for me.
Continue says, drink alcohol while walking. Is that what we should do? Bob says, I like the way you think. This is great.
So,
and then Ed says, how does alcohol help? Careful, doctor.
Okay, let me get the clinical part out of the way, and then we'll get to the fun part.
Okay.
Honestly, don't know. The why is one day worse than any other? I don't know. I will say, leg pain, and this is the fun part for me because I do know that leg pain can come from a variety of sources. I often, believe it or not, I often see a lot of people with lumbar issues because they just get referred for the leg pain. And so a lot of people will have back issues. And so what I see with that is on days when they are particularly active, okay? So the days where they probably do a little bit more, if they got kids or grandkids, they probably went to Disneyland that day, or they were like, oh, I had so much running around to do. The next day is when they say, whoa, my legs are really bad after they slept, probably because their back disease is causing them more issues than their peripheral disease. Peripheral disease is very, very monotonous. The walking distance until pain starts is the exact same, give or take. Unless you're like walking uphill or downhill, you walk 10 feet, that's what it's going to get. 10 feet, it's going to be 10 feet, it's going to be 10 feet, it's going to be 10 feet. The same thing with the rest pain, which is the more advanced size. If it wakes up at 2 o'clock in the morning, it's going to wake you up at 2 o'clock in the morning. There's not going to be this weird variation all the time, because remember, these things are fixed lesions, and that's sort of biologically, that's what we're taught. Because they're fixed and they don't move, it's going to be the exact same thing when that compromise gets overtaken. So, right, I would suspect that either you may have some venous disease, underlying venous disease that isn't necessarily treated. And so again, you're doing more, and so your legs get a little more swollen or a little more puffy, and so a little sore the next day. Or you may have back disease, which is a little bit more aggravated because of how much activity standing, being vertical that day. So that's the clinical part. The fun part is I cannot, as a physician, recommend alcohol while walking around. Does it probably have some anticoagulant effects? The answer is probably yes. How significant those are, yet to be determined. It's just, you don't want to be stumbling around drunk, because if you fall and break your head or something, then it's just no fun. But it's also, as we all know, it's also somewhat of a pain dulliner. And so I would assume that if, you've had enough, and, we saw the old Western where they drink the whiskey before they pull the bullet out kind of thing. That's a real thing, to an extent. So I would assume, if you've had enough, then you're just not acknowledging it as readily as you would having not had any alcohol. That's all.
The next thing we're going to see is all of those wineries that are being, going out of business right now, starting this whole walk and wine.
Yes.
Wine and
Wine
walk.
and
And you're going to see huge university studies on this to show that you can literally improve your walking distance if you walk and wine.
I'm here for it.
So Genia wants to know, her husband actually just had pedal loop reconstruction.
Cool.
And so, but is it normal to have a little nausea after a procedure, like that, with the medications and such?
Yeah. Because we do most angiograms under sedation. And just, I was in this conference, we were talking about, those are pretty long procedures for what it's worth. Most standard PLD procedures take maybe about 45 minutes to an hour. I usually give patients a dose of sedation right at the beginning, and then just don't anymore unless they're having excruciating pain. However, if you're going through this procedure sort of for 2, 3, 4 hours, then you're going to get an exceptional amount of sedative materials. And so, it's the nausea is post anesthesia type nausea, as if you had gotten a general anesthesia, or, the stuff you get for colonoscopy or something like that. So that's actually pretty normal.
Okay. I just have one more question. I don't want to take up we have a million more. We should have you back because you're amazing. And this is fun, isn't it? We have a great group of people watching. The one last question we have is just a fun one. Everyone wants to know, it's not to make fun of them or mock patients, but patients want to know if there was just one story that you just remember that you say, oh my gosh, I can't believe he just said that, or she said that, or I can't believe they just did that. And it's run the gamut. From dogs eating toes and them running to the veterinarian versus I'm not kidding. This was our friend David Armstrong over at USC, the podiatrist that told that story. He's like, they went to the veterinarian first versus coming straight to RER. The veterinarian had to send them to RER and say, get out of here. They're now. So go ahead.
Yeah, this one's a little gross. So if you have a sort of weak stomach, be prepared. I had a patient, this was probably my 3rd or 4th year in practice, and the ER called me the night before and said, hey, we got a guy who's got foot gangrene. Oh, and by the way, he has maggots on his feet. I said, okay, sure enough. And one of the things I say it sort of, tongue in cheek, but I say, leave the maggots on the feet. Because believe it, they clean off all that dead tissue. They do not eat living tissue. So maggots are actually very, very good for some wound care. they washed him off, of course. And, so I come in the next day to see the patient. And the poor guy's sitting in his chair and his family's there. And I'm like, well, how did it get so bad? Because maggots is like really, 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 really way down the line. And the family had said, well, we would go see him. He lived at home alone. We'd go see him, and he always kept a blanket over his feet. And they didn't think anything about it. It's like, oh, just dad, being dad, whatever. So they would sit and chat until probably 2 or 3 months down. It's like, well, something was smelling in the house. And again, they were going around the house. They thought it was like a dead mouse or something or whatever in the house they were looking for, and could never find this thing until finally somebody lifted it up and saw his feet. That's when they brought him into the hospital. I said, well, that story makes sense. I get it. Y'all not going to bother him. He's your dad. Whatever. So then I start talking to the guy, and I'm like, well, we got some work to do. He's like, well, why? I said, well, look at your feet. And so the guy's got his feet up in a recliner, and he's totally with it. And he says, sorry about that. And I say, look at your feet. He's like, why? I said, one looked normal, and the other one didn't. He said, but wouldn't.
Oh no. This is like one of those cliffhangers. Oh no, man, of all the questions that we end up freezing on, everyone, how do you think the story's gonna end? Oh my goodness. We have had quite a few patients that have ended up with maggots in their feet, in their wrap. And yeah, it's gross, but those things will clean the heck out of that. And so if you do end up with that, wrap it on up and get to the emergency room. Chances are they're not going to clean them out right away. They're going to wrap it and let them do their thing, and then they actually go ahead and wash them off. But we have had that happen quite a bit. But please, dear God, if you have a wound, do not go out and get roadkill and bring the flies in. Like, keep your windows shut. Keep your windows shut. If you see any flies, keep them away. And it's not even a joke. You have a wound, you keep that fly away. So we'll let you continue where you left off. It was like a cliffhanger. So
yeah, no,
coming up next. So coming up next, right here.
Yeah, we just had to keep going back and forth until finally, I had to pull his family outside, and they had a conversation later. Unfortunately, I never got to treat the guy. It took that long between family coming in and having discussions with him and all that kind of stuff. But yeah, that was a really surreal sort of conversation, having to go back and forth when he's like looking and recognizing that they look different, but because it didn't hurt, he thought it was pretty normal. So.
Oh, that's always tough to explain. And that was like the one case that we had with Dr. David Armstrong, that he was like, he had diabetic neuropathy. He couldn't feel it. So he had no idea and thought it was cute that the dog was licking his wound.
No.
Yeah, don't let the dog eat your toes, please. And keep the cats away from those wounds too, please. But thank you so much. Dr. Mack, we have to have you back again.
Happy to.
We would absolutely love it. He's over there in Kaweah Hospital over in Central California, about an hour south from Fresno. But we really appreciate you being here. We appreciate you being open to new and advanced, limb salvage, and giving our patients the best chance to walk to live another day and live to walk. Everyone who's watching, make sure you email info@padhelp.org if you want to be in our live studio audience, and subscribe to our channel. Have a great week, everyone.